Okay, we'll begin now. Chancellor Diermier, over to
Thank
you.
you. Thank you very much. Thank you, Neha. So first of all, good afternoon to all of you. And thank you for joining us for today's medical town hall. This is an excellent opportunity for faculty and staff to come together and learn more about the latest understanding and the science behind our fight against COVID-19. We have put together a great panel of world-class experts, both from Vanderbilt University's Medical Center and Vanderbilt University. We had almost 700 people registered for this event, which just kind of shows the tremendous interest in this. We also have over 20 questions already pre-submitted, and we will get to as many questions as we can. And those that are not addressed, we'll find answers to and then provide them to the extent possible on the Return to Campus website. It's been clear from the discussions over the last few days that as we're preparing for the return to class, questions about safety, the health, and the medical side are front and center for everyone. As you know, we are committed to providing unique and enriching experience of education and discovery for our students and for faculty, but we want to do it in an environment that's safe and that is making sure that we are basing all of our decisions on the best possible science and public health information that we have at the time. There is no perfect safety for this, but we are doing our very best to minimize the risk for everyone. And we are extremely lucky to have a great partnership with Vanderbilt University Medical Center, and the resources that come from that partnership and the resources that come from our School of Nursing that just provide a level of expertise and capability that enables us to move forward with our return to campus plan. It's clear, and of course we're all aware that many of our safety protocols and guidelines will have a significant impact on your teaching methods, how we're thinking about education, and how we make all of this possible in the context of COVID-19. It's clear that the fall semester will be unlike any other that our university has experienced, but I'm particularly grateful for the collaborative spirit that I've seen over the last few weeks for us to work together to make sure that we're providing the education for our students that we're known for. So I appreciate how that you're joining us today, but more importantly, I appreciate how all of you have stepped up over the last weeks and months in order to enable us to move forward. With that, I'm honored to introduce today's speakers and panelists. My co-host, Susan Wente, will moderate today's conversation. Of course, as you all know, Susan is Vanderbilt's Provost and Vice Chancellor for Academic Affairs. Today, we're also joined by Dr. Jeffrey Balser, who is the President and CEO of Vanderbilt University Medical Center and the Dean of the School of Medicine. We also have with us today Dr. William Schaffner, who many of you will have seen from his appearances on CNN and other news outlets, where he has been a very powerful voice explaining various aspects of COVID-19. He's a professor of preventive medicine, health policy, and infectious diseases at Vanderbilt University Medical Center. We also have with us Linda Norman, who's the Valere Porter Menefee Professor of Nursing and the Dean of the Vanderbilt School of Nursing. Pam Jones is with us today. She's the Senior Associate Dean of Clinical and Community Partnerships for the School of Nursing, and she's also a fellow in the American Academy of Nursing, and she will particularly talk about contract tracing, testing, and so forth. And then we have with us Dr. Andrew Churchwell, Vice Chancellor for Equity, Diversity, and Inclusion at Vanderbilt University, and Chief Diversity Officer for VUMC, and also, of course, a distinguished member of the faculty at Vanderbilt University Medical School. And finally, we have with us Eric Kopstein, who's the Vice Chancellor for Administration at the university. So thank you for all of us for joining us, and thank all our panelists for your time and expertise in today's discussion. I will now hand over the panel to Dr. Balser, who has been a fantastic partner for us in steering the Vanderbilt University's Medical Center with this excellent leadership through this global pandemic. Jeff, over to you.
Thank you, Chancellor. We are feeling very good about how things are progressing, even though nationwide we are certainly dealing with serious challenges. I think the best thing I could do is give a little bit of context Vanderbilt University Medical Center really has been leading the care activities for, at a minimum, the middle part of Tennessee, but in many ways for the entire mid-southern region, and certainly in certain aspects for the entire country. And I want to put that in a little bit of perspective. Our infectious disease teams are really an historic source of world leadership for us. And not only are they very well known around the globe, but we actually are one of the rare places that have world leaders in coronavirus. Folks that have actually were leading studies of coronavirus before anybody understood that coronavirus was very important. One of those individuals is Mark Dennison. He's our chief of pediatric infectious disease. And Mark, if you want to look up Mark, there's a wonderful article by Gina Collada, who writes for the New York Times on May the 1st. And it describes the role Mark has played worldwide in developing our understanding of coronavirus, and in particular, his lab did all the preclinical work for remdesivir, which, as you know, is now the only drug that's known to reduce the length of illness with coronavirus. And because of that synergy, we were able to very effectively develop our own testing strategy at the medical center extraordinarily early. And for this audience, the real advantage to that is it's allowed us to do the one thing that all the public health experts believe is most important, and that is test. And we were actually testing so much in Tennessee in March that it looked like Nashville was the only place that had coronavirus. And the reason was we were the only people that had a test at high scale. We were doing 1,000 tests a day in the middle of March. That has really played into our ability to work with the city and have the city feel it has really, really good data showing what this virus is doing. So unlike many places around the country, and certainly unlike many places in Tennessee, the infection is not out of control in Nashville. We have avoided becoming a hot spot, even though admittedly we are seeing a growth in number of cases. That relationship between Vanderbilt and the city has allowed us to participate heavily in drafting the city's shutdown plan and then its reopening plan. We wrote many of those sections, and we constantly communicate. I talk to the mayor routinely about how things are going. And the head of the coronavirus task force for the city is Alex Jahangir, who is the leader of our orthopedic trauma group. So the connections deep into the city and the ability to work dynamically to react to conditions on the ground has played a big role in our success in managing coronavirus at Vanderbilt and at Nashville. I would also mention Vanderbilt's a pretty good place to be if you do catch coronavirus. When I'm a pulmonary and critical care is also an historic strength here. And when I'm personally an ICU doctor, and when I was doing my fellowship at Johns Hopkins, I read the papers I read on expert ventilator management and infection were out of Vanderbilt. So this is something we're very, very good at. And I think that's been manifest first in us guiding a lot of the national policy around how to take care of COVID patients. Some of the papers you're reading and things that you're seeing in the major media come out of our groups. It also is manifest in a very low mortality rate. The mortality rate in Nashville, and certainly at VUMC, since we're a large percentage of that care, is under 1%, well under 1%. And many of you know the national death rates range anywhere from 2 to as high as 4%. So I say all that to give faculty and staff confidence that as challenging and as difficult as this is, we come at this from a position of strength. I'd close by saying that we are all constantly trying to look into the future and understand what's going to happen next. Just to give you a sense of the status of this, we have today about 38 people in the Vanderbilt inpatient facilities who are sick with coronavirus. In early May, when this was at its low ebb, it was 25. So we have more, but not dramatically more. And we are seeing that through modeling, while the R0, that number that we follow that says how many people are likely to be infected if you get infected, that number is roughly 1.1 in Nashville, which is higher than we'd like it to be, but a lot lower than in the rest of the state. And what we're seeing is that the early action by the mayor to move us back quickly from phase 3 to phase 2, to require masking in Nashville, we're seeing those effects even through cell phone data that our Department of Health Policy is able to track and show us that the city and the region is reacting to these warnings. And I believe that's playing a major role in helping us slow down the growth of this and really keep it under control. So I'm certainly not predicting that we won't see more cases. We know we're going to see more cases, but we don't feel we're going to see so many that it's going to overwhelm us, or that we're not going to be able to manage effectively in our hospitals over the next several months. I think I'll turn it back to you, Susan.
Okay, well, thank you very much, Dr. Balser. And I also want to extend my thanks to all of the faculty, staff, and postdocs who've joined us today. And I hope that you're all doing well as we continue to navigate these difficult times. I appreciate your innovation, your flexibility, and I especially appreciate your feedback. We are listening very closely to all the questions that you are raising. And I appreciate also how we will continue to work together to support our missions of education and research. Now, Dr. Balser, thank you so much for addressing kind of the Nashville situation and how that impacts our Vanderbilt community. I think that was very helpful for our faculty, staff, and postdocs to hear. And I want to turn right now and jump into other questions that we received from our faculty, staff, and postdocs. And in particular, give an opportunity for Dr. Schaffner to share his expertise with us. He shared it with so many audiences, as Chancellor Diermier pointed out, throughout the course of this pandemic. And so from a scientific standpoint, Dr. Schaffner, what are some of the points that are most important for us to continue to understand as a community?
So, Susan, glad to be with you. Hello, everybody. Yes, this is a highly communicable infection. We know that. And information needs to be communicable also. Communication is key. That's why we're doing this. And we hope to continue to do this throughout the year as we share and abide by the guidelines that we've set out, the rules of the road, as you will, which we will use to interact with each other. We need to remind ourselves and others as we negotiate these, this new normal, because it certainly is not the old normal. Let's pause for a moment and recognize what an extraordinary biological event this has been. This entire global pandemic is as a consequence of one virus jumping species from some animal, the source of which we don't know, once to one human being, likely in a wet market in Wuhan, China. All the other subsequent human infections have stemmed from that one single transmission. This virus is extraordinarily communicable. In a few short months, it has circumnavigated the globe. It has now struck every continent on the globe, except, I think, Antarctica. So it's entirely contagious. As the Chancellor said, what we're trying to do is reduce the risk. I like to quip that I don't like to use four-letter words such as safe, because that implies complete safety and perhaps the notion that we can prevent each and every infection. I don't think we can, but by doing a whole series of things, none of which is perfect, they all have their gaps, but layering them together, we can substantially reduce the risk of transmission and the hazard of infection, not only in our community, but on our campus. As I say, this is an infection that is transmitted readily from person to person, and we in public health think that that is the major mode of transmission. Within 6 feet of each other, in enclosed spaces for prolonged periods of time. Can it be transmitted out of doors? Certainly. There's been a lot of discussion about airborne transmission, namely not just close, but can this virus be wafted distantly and be transmitted in that way? Theoretically, very likely, probably has happened, but it is also likely not a very common mode of transmission. This reproductive number, R0, for such airborne viruses is measles, for example, which is probably the most transmissible virus we know, is up around 18. In other words, one person who's infected can infect 18 susceptibles around them, even those great distant. The R0 around the country now for COVID is around 2 or 3, even less in Nashville, as Jeff Balser has just told us. That's really indicative principally of close person-to-person transmission. That's what I like to call the highway of transmission. Lots of viral traffic on that highway. Airborne, could it happen? Yes, but it's more like a side street. Some of the viral cars can get through, but not too many. So let's not put the emphasis on a more remote syllable. Avoiding close contact or the consequences of close contact are critical. Masks are key. We'll say more about that in a minute, but I'll revert now and change my mind and use some 4-letter words. Mask is safe and mask will work. We'll have to look at that 6-foot rule and try to abide by it. Avoid large groups, lots of good hand hygiene, disinfection of surfaces. We're going to put a lot of these interventions together to make our environment as safe as possible. I'll have another chance to get back to this later, but I'll give you my first dose now. It's also important that come September and October, we all get flu vaccine. We'll talk about that again in a minute. Susan, back to you.
Well, thank you for that very, very helpful and insightful information, Dr. Schaffner. As a follow-up, one of the questions that we got was in terms of the effectiveness of the various types of face coverings, face cloth masks, N15, face shields. How effective are the different types in slowing the spread and preventing infections? Can they be reused? What's the most appropriate type for individuals in our university community?
Well, masks are absolutely critical. They are a fundamental way we are interrupting transmission. And frankly, if I had my way, every single human being in the United States, when they leave their front doors every morning, would wear their mask. Masks come in different varieties. It's important that they be used. The cloth masks are very, very common. So are these surgical masks. They are very, very effective. The cloth masks, unless they get soiled, otherwise, you might think about washing them about once a week. As to face shields, that's also something that's rather new. If they cover you from the forehead down below your chin and are structured so they come around your cheeks, I have some colleagues who think they're probably about as effective as a surgical mask. So they are clearly going to be used, and we'll, I think, see them used more as time goes on and more people try to use them. You mentioned briefly the N95 respirators. Those are much more serious. We use those in the healthcare environment. You really ought to be trained to put them on correctly, and they're not currently recommended for community use. But the emphasis is using the mask. A couple of other things very quickly. There's a lot of stuff on the internet that the mask will somehow be disadvantageous to your health, that it will interfere substantially in your breathing, reduce the amount of oxygen that comes in. That's incorrect. That you will build up your carbon dioxide, the bad air, and not permitted to be exhaled, that's also malarkey. Not correct on either score. Masks have two functions. One, to protect you from me so that my infection can't reach you. And of course, that's very important because as we've all learned, this is such a contagious infection and such a sneaky infection that I can be without symptoms and still have the virus. We can have asymptomatic infections. Hence, once we learned that, then clearly the rationale for masks became important. The other thing we learned is, and we've learned more about this going on, masks protect against incoming also. Perhaps not as much as outgoing, but nonetheless incoming. So the wearer is also protected from those around them. Works in two ways. So masks are absolutely fundamental, and here going forward in Vanderbilt, we are going to oblige everyone to be masked.
So following up on
Susan?
that, yeah, following up on that, we had another question about if everyone is wearing a mask, do we still have to maintain distance? Do we still have to maintain that 6-foot physical distancing without masks?
Surely. Remember, I said we're doing a series of interventions, none of which is perfect. So we want to do them all simultaneously, and that will give us a series of layers of protection that will together reduce the transmission likelihood of this virus. So outdoors or indoors, keep your distance, just stretch out your arms. You can figure out what 6 feet is approximately. Keep away from folks. And the other thing is avoid group gatherings. You know, the magic number, it's not so magic, but at the moment is about 10. Avoid groups that are larger than 10.
Great. Thank you very much, Dr. Schaffner. I think that was incredibly helpful for our audience. And I'm going to shift gears and give you a little break right now. And I'm going to turn to Dean Norman and Associate Dean Jones to address this question that's come in from our audience. And that is that as COVID-19 cases surge throughout the country and testing is in high demand, has Vanderbilt secured all the necessary testing supplies for the coming fall semester?
Thank you, Provost Wente. I'll take this one. We have been working, as Dr. Schaffner said so well, on an integrated approach to multiple strategies, and testing is certainly one of those integrated components. And it's top of mind with people because everybody's worried about the availability. And what I want to say is that it will be part of an ongoing program of testing, contact tracing, as well as symptom management and case coordination, if you will. And the first thing I'll say about testing is that with our partnership with the medical center, we have available testing, ongoing availability for symptomatic individuals through occupational health or student health and the testing sites that Dr. Balser has already mentioned. In addition to that, we'll be providing an asymptomatic testing program for screening and ongoing population assessment of the disease load in the population. And we have worked with Eric's excellent procurement team to create strategic partners with several vendors so that we have those testing supplies available. A core component of the testing program is to build it in a flexible way so we can flex up and down based on what the need is. And we will do that informed by data and working with our community.
Okay. Thank you very much, Associate Dean Jones. So you mentioned within that context, testing asymptomatic. And I know one of the questions that we've gotten is the concern about young adults being asymptomatic carriers and that they may lack the judgment and experience to assess the risks associated with COVID-19. Would you be able to comment on, or anyone else who would like to comment on, perhaps Dr. Schaffner too, on the best public health practices for influencing this population to take action?
Well, I'll make a comment and then I'll let Dr. Schaffner add about asymptomatic spread. He's certainly more of an expert on that than I am, but there's been a tremendous effort with the communication and with all of our excellent leaders and academic leaders and faculty to develop a plan that engages our student body in an awareness of what they need to do to protect themselves and to protect our faculty and staff and to protect this community. So I think a big part of it is a combination of just a public health awareness push. Clearly, we're going to have to be vigilant about it and work as everyone will be role models. Our ambassador program will help us with that quite a bit. But I think it's going to be all of us working together to keep our risk as low as we can. And I'll let Dr. Schaffner add to that.
Just to reinforce absolutely everything that you've said, communication, 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 and then good role modeling and being aware. And when we see issues come up, to respond to them in a diplomatically but firm fashion. It's clear that transmission from people who have no symptoms or mild symptoms, so mild that they probably don't conceive of themselves, don't identify themselves as ill, is very important in transmitting this highly contagious virus in the population. So avoidance of large groups will be important, and we'll just have to stay on it and keep talking about it.
Okay, thank you very much. Much appreciated. I think the other aspect of this is faculty and staff members themselves having questions about their own testing if they are asymptomatic, and whether or not they will have the opportunity to be tested even if they're not showing symptoms or have not been exposed to COVID positive cases. Dean Norman, or?
One of the things that I think is important for faculty and staff to understand is that if they are exposed to someone who has tested positive for COVID, then they'll be contacted by someone in contact tracing. So I think they can rest assured if they haven't been contacted and someone in their area has become positive, that means that they're not, they really were not exposed. So asymptomatic testing is one where there are a lot of issues with it. If you test too soon, you will not, it's not going to show up. The CDC and Johns Hopkins says it takes about 8 days in order for somebody to be able to to test positive if they've been exposed and if they were developing COVID. Just because you're exposed doesn't mean you're going to get it. So asymptomatic testing really gives you one snapshot in time with it. And if someone has been exposed, then the recommendation is 14 days in quarantine to be able then to make sure that they're not going to be able to spread it to someone else.
And just to add to that, as I said, we've built a testing program that's flexible, and this is evolving daily. The situation is evolving daily. So should we need to enhance that testing capability, we will be able to do so.
Okay, thank you very much for clarifying this for us. It's very important for our faculty and staff to know about the testing plans. As a follow-up, we often hear those terms, and so I'd like to just reflect one more time and come back to this definition of who is defined as being a close contact and what does it mean to have been exposed?
So a close contact is someone, you have been exposed to someone who's positive and you've been less than 6 feet or more than 15 minutes. So when you think about the strategies that the university has put into place of everyone masked and that we have had 6 feet distancing, and go take a look in our classrooms and you'll see how everyone is spread out for six feet. So as long as people adhere to masking 6 feet distance, then it will be difficult. But if someone has been exposed less than 6 feet for more than 15 minutes.
And let me just add a little more to that, because I do think there's tremendous anxiety that people, they don't understand that you really do have to have this type of significant contact, according to the CDC, to be at any significant risk. And what we've done is really put together a very powerful contact tracing program. We've amassed a team in partnership with the medical center of excellent, well-qualified nurse practitioners who will be working with me and involved in doing that. On the student side, occupational health has a very robust program in place on the medical center side that's been in place. And we'll be coordinating all of those activities through a central command center structure. The key to contact tracing is rapid response. And we know that the health department has a longer lag time than is tolerable for us because of our residential living and other things that put our community at risk. So we have supplemented with work of everybody in the leadership at Vanderbilt University to build this contact tracing program so that we will be doing that contact tracing within 24 hours. And that is a powerful tool to be able to get individuals who are truly close contacts out of the community into isolation or into quarantine as appropriate.
Okay. Thank you very much. I think your comments in terms of risk and relative risk also bring us to a question that's been raised by the faculty and staff that's very relevant in these unusual times. We know that the pandemic has taken a disproportionate toll on minority communities and people of color. Dr. Churchwell, I would really appreciate hearing your thoughts on this and what action steps are necessary.
Well, thank you, Susan. I think some preliminary comments about the race and minority issues are really important at this time. It's clear the stress that African American and Hispanic members of our population and other minority groups face has direct negative impact on their immune system. The chronic stress model clearly enhances your ability to get infections, particularly infections with this virus. You couple that with the social determinants of health, which are really evident in our race, in our African American, Hispanic, Native American, and Alaskan communities. And what you see is that social determinants of health really speak to those things that affect your health before you even get to the hospital. So the access of care is important, poor nutrition, access to real leafy vegetables and the like. And just having a minority status itself leads you to have additional risks. Now you layer on top of that, again, the third thing, which is the preponderance of comorbidities, diabetes, obesity, hypertension. All of these raise your susceptibility to viral infections and leads to the CDC data bank that shows that you have higher rates of hospitalization for our minority communities, the African American and Hispanic communities, almost 5 times our white counterparts, and 2 to 3 times the death rates based on where you are in this country. So that really shapes a lot of how we think about where we test, how we test, and we actually, using this data, really helped our National Metro Health Department know where to go look for the problems, shift their testing in our communities. Shifting gears a little bit, we encourage our faculty and staff and postdocs to reach out to the Employee Assistance Program. That's run by Jim Kendall and a team of great consultants and counselors. They have access to a host of other things that you may well need as you deal with the mental stress issues of this problem. So I think, Susan, there are a lot of things we have available here at Vanderbilt, and we have to be attended also as the medical center as to those specific issues that our minority communities face too.
Thank you, Dr. Churchwell. I know that our faculty and staff, of course, care very much about our student population also, and are also thinking about the mental health and wellness of our students. Do you know of any specific actions that Vanderbilt's taking to help support our students during this time also?
Well, we have through GL Black and who's one of our Dean of Students, Associate Dean of Students, has created the Student Care Coordination Team, which is a triage system in the university. So if a student comes in with a problem, whether it be mental health or just a wellness issue or a true medical illness, that person is then triaged to Student Health Services if it's a medical problem. They're triaged to the University Counseling Center And there we have counselors, up to 20 counselors. And as you so well know, because of the issues around minority students, we've actually added 6 additional counselors of color there, particularly women. And we've also had additional Hispanic and also Asian counselors added to that team. So we're very specific and intentional about building our counseling services to be sensitive to the needs of all of our minority populations when they come to us for counseling issues.
And Provost, if I could just add that the contact tracing team as well, part of that process is a very in-depth interview with the individuals who are in isolation and quarantine, identifying any comorbidities that might be there that need to be addressed. We actually have a psychiatric nurse practitioner as part of the team to be very thoughtful about how do we support those individuals. And then there will be ongoing wellness checks, and we'll work in partnership with student health should we see any warning signs with those students, because it's going to be very stressful to be in isolation and quarantine, and we need to be very attentive to that. Our faculty are right to be cautious about that.
One other thing, Susan, just to close on this point, and Pam really helps echo it, the Student Care Coordination Network is actually a true network. Once they encounter a student, they follow up. There is a loop of continued assessment and follow-up that takes place. Students are not just seen once and sent back to the dorm. So I think we've really invested well in this.
Thank you very much for all these different perspectives, and especially for all these different avenues of support for our faculty, staff, and our students. This brings me to a question that I think, Dr. Schaffner, you referred to previously, and that is one that's been raised by our faculty and staff. Dr. Schaffner, can you explain how COVID-19 is different from the flu? And also, could public health information related to COVID-19 also be an opportunity to encourage flu shots? I think Dr. Schaffner, I think we need you to unmute your phone. There we go. Okay,
there we go. Thank you very much. So Susan, thank you for this opportunity. Yes, influenza and COVID are both respiratory infections. They're transmitted in an entirely similar way. And to make things more vexingly difficult for clinicians, they can actually present with very, very similar symptoms. So this fall, when influenza rises, as it always will, we don't know how severely, but there'll always be an influenza outbreak. We're going to have, as clinicians, difficulty in distinguishing these two infections. So that'll be another challenge. We think COVID is a more serious infection in that we think its fatality rate, hospitalization rate, et cetera, on the basis of the data we have today, are probably higher than influenza. It can make the body, the various organs in the body more dysfunctional than can flu, although flu can be terribly bad also. We obviously have some treatments now for both infections, but we do better, I think, in treating influenza still than we do with COVID. Another striking difference between influenza and COVID is the role of children in these infections. From the beginning, a striking epidemiologic feature of COVID was that the children and young adults were much less affected than they are with influenza. In influenza, children have what we call the distribution franchise in our communities. They shed much more virus than do adults. They're the less hygienic part of the population, so they spread it amongst themselves, and they shed the virus for longer periods of time. So they really are the distribution engine of this virus in our communities. Whether that's comparable in COVID is really not known and is currently under study, including by some faculty here at Vanderbilt. So those are some of the differences. And then lastly, but certainly not leastly, we have a vaccine against influenza. The recommendations are simple. If you're older than 6 months of age, you should be vaccinated each and every year. This is not the time to go into all the details. We recognize that influenza vaccine is a good but far from perfect vaccine. But I also like to paraphrase that old French philosopher Voltaire, who admonished us that waiting for perfection is the greatest enemy of the current good. We have a pretty good vaccine that can do a lot of good. It can prevent an awful lot of infections completely. And even if it doesn't prevent the infection completely, your influenza infection is likely to be less severe. You're less likely to be hospitalized. You're less likely to be admitted to an intensive care unit, and you're less likely to die. I'll take it. Thank you very much. We all should get vaccinated. That will also help offload some of the illness issues from our already kind of stretched medical care system across the country. So come September and October, I hope everybody rolls up their sleeve and gets vaccinated. We do Flulapalooza, and we hope to see you there.
Okay, well, thank you very much, Dr. Schaffner. So we've also had a few questions come in about the evolving situation in Tennessee and Nashville and how that could impact Vanderbilt's plans for in-person instruction or other in-person activities, including research activities. And I'll share my thoughts, and then I will ask Vice Chancellor Kopstein to please feel free to chime in. I think one, you can see from this panel discussion that we are working incredibly closely with the Vanderbilt University Medical Center and with our School of Nursing colleagues to closely monitor conditions, to assess new information, to develop new safety and prevention protocols as they become available. We will continue to be incredibly vigilant, just like we've been all along, and we will not hesitate to make changes should they be needed. For example, even since mid-June, when we announced the plan that we would have in-person classes for the fall, we've continued to look for opportunities to de-densify the campus. And we've made significant strides forward in terms of that. Also evidence that we've been adapting our plans based upon what's working in the research spaces that have been open and operating for the past 2 months. I think the most important point I can convey to you is that we have a plan that's nimble, and it's flexible, and it's responsive, and that we've been cautious in every step, and that we will continue to do so because our people are incredibly important, the most important thing to this university. So Vice Chancellor Kopstein, would you like to offer any further comments on that in terms of our plans and how we're moving forward?
Yes, certainly, and thank you for the opportunity, Susan. I think you touched on a number of key factors. I'd just like to add and emphasize that our plans are really based on our objective to fulfill our core mission of on-campus teaching and instruction. And as Susan said, our plans are really premised as well on the principle of flexibility and are designed to create the ability for us to adjust. I mean, we can switch to an entirely online mode of course delivery if necessary. We did that very quickly in the spring, and we're now even better prepared to do that so we can ensure the ongoing continuity of an outstanding education in an online environment should we deem that that becomes necessary. Also, I'll say our testing and disease surveillance program that you heard about from Linda and Pam is going to provide us with current information on cases and spread within the Vanderbilt community. And with that, we'll maintain the ability to adjust on-campus operating levels very quickly, as well as for discrete periods of time. And then I think just, my final remark on this, Susan, is that I'll say that, research universities never close, even if operating levels and approaches are adjusted. Even during a pandemic, we have a range of mission activities underway, including research. We have people living on campus year-round. We have hundreds of buildings and millions of square feet on a 335-acre campus that includes a world-class medical center. So we'll continue to monitor the local situation while remaining open and accomplishing as many of our campus mission objectives as possible. And we're positioned to make adjustments as we move forward that will mitigate risk for our community.
Thank you very much, Eric. Thank you. Well, we're nearing the end of our time together, and I'd like to close this question and answer discussion by looking to the future again. I know Dr. Balser, you made some comments about the future, and Dr. Schaffner, you did also, but could you just tell us again what your thoughts are about the future of the pandemic in terms of its overall duration, its ongoing impact, and how our actions and accountability as a community can be a help in terms of that?
Well, I would just say that this is one of those hope for the best and prepare for the worst situations. Vanderbilt Medical Center, in fact, will be playing a central role in the testing of the NIH Moderna vaccine. We've played a huge role in the New England Journal paper that just came out showing that the vaccine does create an immune response in healthy individuals, and now there's going to be a 30,000 person national trial that will play a major leadership role in conducting. That said, it's going to take time. Imagine how long it takes to vaccinate 30,000 people and then follow them long enough to know whether they actually get coronavirus if they get exposed. Think about how long that process really is. So even under the best case scenario, it's going to be a year or more before we have a vaccine that could protect the public. And it may be substantially longer than that. So I think what we should be about right now is the kinds of things we've talked about today, the best ways we can stay safe while conducting our activities to the greatest degree possible.
Well, I'll just echo what Jeff said. It is a new normal, and we need to think about going months into the future. Masks are fashion forward. It's something that we will just be getting used to, along with all the other adjustments in our lives, both professional lives, educationally, as well as our private lives and recreationally. It's not always comfortable, but we need to do this all together. At the moment, I have to tell you, my view of what's happening on the national scene is a little bleak. On the other hand, as I look locally, again, to echo Jeff, we're doing pretty well in Nashville at the present time, and communication between ourselves and our community's political leadership is excellent. There's lots of cross-communication and mutual support. We're going to be all in this together. We will learn more things, and I hope that vaccines will develop. And let's keep in touch with each other. We all have to remain open to new information and flexible as we go along, and committed to the new normal of being basically very cautious as we go about our daily affairs.
Thank you very much for that.
Susan?
Looking forward. And I would like to now turn it back to the Chancellor.
Well, first of all, I want to thank our panelists and speakers for this extremely informative panel and discussion. I also want to thank all of you for joining us today, our staff, faculty, and postdocs. As you see, there is an enormous amount of activity that's going on. Our approach has always been based on science and the best public health information available, and it would continue to do so. Given the resources that we have in place, you've heard about the extraordinary work that was done and has been done, is continuing to be done on the basic biology of the virus, treatment options, development of vaccines, modeling, engagement with the community, contract tracing, testing protocols, even how we deal with particularly vulnerable populations. So this is a massive challenge, but I would say that here at Vanderbilt, because of our partnership with Vanderbilt University Medical Center and the tremendous work, School of Nursing and everybody involved, we're in as good a shape as one can hope for. Having said that, as I said before, it's a massive challenge. It's arguably the biggest challenge our generation is about to face. It's certainly the biggest challenge in the history of the university. And what that requires from everyone is to step up, to be involved, to work together in a collaborative fashion and as one community to address these challenges. So I want to thank everyone for their tremendous work on that. for their willingness to be engaged, for the spirit of doing this together as one community. I want to thank you again for joining us today. Stay safe, and we'll continue to work on this together. Thank you.